Okay, Adrian is asking for patients after 5+ lines of therapy, also including some of the CAR T therapies. Is there a possible role for allotransplant? And Dr. Matsui, I think you should probably answer that one.
So I think that the critical part of thinking about an allotransplantation transplant is really, I think you have to be in an exquisitely good remission at the time that you go to an allotransplant. And so I think that it's a matter of, like, people ask, what do I need to go to an allotransplant? And I say, look, you need to have a donor, you need to have really great, be in really great health, and you have to have a really great remission. You have to have good disease control. So at Hopkins, when I was at Johns Hopkins, we had looked at our allotransplant data, and there we had about 30% of people like doing really, really well over years, like decade plus, right? No relapse, well-controlled GVH, all of that. But universally in those patients, the major thing is that they had a really good remission going into the transplant. So I think that there's something weird about having myeloma around that just poisons everything else. So if you have myeloma around and then you put in a new immune system, there's something not great that happens. I think that if you have sort of a clean slate, then you putting your myeloma in, then I think that's the time where you can get the best efficacy. So what I recommend is that patients should talk to if they're interested in allo, talk to someone who might be interested in doing an allo, but I would never do it at this point in time unless you were I saw no myeloma at all. Because I think that the chance of relapsing is very high if we see something going in. So even if you have a VGPR, I think you're going to relapse. So there are strategies, what we're trying to do is to develop strategies to use after an allotransplant to try and improve that. And it makes sense because there you have a fresh, new, ready to go immune system, and you got to take advantage of that. But you can't disadvantage it in the beginning by having disease around. So I think you can do it, but it's got to be done in the right condition.
Interesting. And you're a real expert in allo, so that means a lot coming from you. Okay, DM is asking if the first bone marrow biopsy included a FISH test that did not have deletion 17, but the second bone marrow and FISH test does have it, is the patient considered high risk? Dr. Brand, do you want to give us a start with that question?
So, yes. The answer is most likely the disease does change. Now, in terms of deletion 17p, we now know that there are many different types of deletion 17p. There's what we call a heterozygous deletion, so meaning deletion 17p is when you lose part of the chromosome 17 on the cancer cell, and it's a tumor suppressor gene. So when those pieces of the chromosome are lost, the tumor proliferates very rapidly. So if you have two chromosome 17s. If you lose one, it's not as high risk as if you lose both. And the FISH test doesn't tell us the answer to that. If you have what's called heterozygous, or one copy loss, or homozygous, two copies lost of chromosome 17. You can tell that you can tell that by gene expression profiling, but not by FISH tests. So if you're a true deletion 17p, even if it's at the second bone marrow, yes, your disease will behave more aggressively. If you're only losing one copy, then not as much, but certainly I would consider that to be a more aggressive behaving myeloma.
And that's called clonal evolution, right? I mean, the Mayo Clinic has this famous slide that a lot of people use in presentations that show the different evolution of a patient who started out with maybe 4 different clones, and that by the time they are, through all these courses of therapy, they passed away from a clone that didn't even exist at the beginning. So,
and that's part of what we do when we treat the patients, because what happens is the myeloma cells that survive the treatment are more aggressive and more heavily mutated. And that's how clonal evolution develops. And it's not like we have an alternative. We can't not treat. So there really is no good way to avoid clonal evolution other than use your best treatments first and
Yeah.
get all the clones that you can in the beginning.
Yeah, I'm glad you emphasized that. I think you both did. So Rick is asking a question, and I know you can't give advice to individuals per se, but this is a good question for a larger number of patients. So 1420 translocation 1Q gain, had stem cell transplant in 2015, achieve MRD negativity and stringent CR. So after 3 years on Velcade maintenance, the doctor's suggesting kind of a vacation, drug break. Um, some people say stay on maintenance, and some people say when, well, you know, I think that's where the whole field is headed, especially with this MRD testing. Like, at what point can you stop maintenance? But it's working for him. So, you know, what do you think about both of
Don't
you?
fix what's not broken. If you know something's working, if you're not having side effects, leave it alone. And that's from somebody who usually does not do maintenance. So I wouldn't change anything.
Dr. Matsui, what do you think?
So I think that, like, as far as, if you think about maintenance, maintenance is treating something that doesn't need to be treated, but with a promise of something in the future, right? Because you have no active disease at that point in time. So you're not treating something to like make it go away. You're trying to prevent something from coming back, right? So that's a very different situation than if you're treating someone who's sick from myeloma. You need that myeloma to go away, for example. So in the maintenance setting, there are things you have to think about. Like, I think one of the very important things when we think about like looking at clinical trial data is that, if you're going to go through maintenance, right, and it's this promise of something, that promise should not be progression-free survival. It should not be the time you go until you relapse, because you're going to get treated at that time of relapse, no matter if you're on maintenance or not. It should be something like you gain something like an overall survival benefit. You live longer if you're going to put yourself at risk of being treated and undergoing, the potential side effects in the context of not knowing whether it's going to work or not. I think that, like, in the times where you're on maintenance, I usually tell people, look, if we decide to do maintenance, then I think you should be on maintenance for until you relapse or you can't tolerate it anymore. Otherwise, I don't think we should do maintenance. There's no study that has ever shown that a specific duration of maintenance actually improves anything. Like, the data that we have, especially in the post-transplant setting, is that you really give maintenance forever until those two situations occur. And so I think if it's tolerated, I would not do it. I think that if it's debilitating and there are a lot of side effects, then I think that I would probably either switch or I'd most likely stop.
Okay, yeah. That's like you said, it's chess game, right? Like, what do we do? It's hard to know. Barbara has a question from Italy. Has been stable in progression for a while, but the myeloma is starting to affect her kidneys. And she is in Italy. The only option the doctors are offering is stem cell transplant, which she doesn't feel ready for. Are there other options? Are there drugs that she can use to protect her kidneys without going through transplant? And sometimes I think patients are a little hesitant to think about transplant, but in my opinion, as a patient who's undergone that, like, you can get your myeloma therapy kind of like you said, like all at once, or you can spread it out over a really long period of time and you still get the therapy. So thoughts on that question?
I think that, like, one of the things to think about is that, like, if there's certain types of organ damage where you cannot readily reverse them, right? And so I think that you don't really want to go to a place where, if there's a potential of really doing something that is permanent, then I would be a little more concerned about that. So, like, if you're anemic, you're probably going to be able to we can just give you a bunch of blood transfusions and you're no longer anemic. If you end up running into bad renal failure and you need to be on something like dialysis, yeah, we could try to get you off of dialysis, but that may not be the case. And so I think if you're starting to see evidence that there's end organ damage, especially renal insufficiency, I am more skittish about not trying to do something that actually makes the myeloma go away. And I think that transplant here can play a good role in actually getting rid of stuff so that you buy yourself some time in a window where you don't have disease that's attacking your kidneys. So I would still think about a transplant. I think that if you were dead set against it, then I would never ever do it. And I think that coming up with alternative strategies at that point is, that's the other option.
Mhm.
I think that when you're talking about kidneys, time is of the essence. The quicker you can get that myeloma out of your system, the more likely you're going to reverse the kidney damage. And so transplant is a great option. There hasn't been a study that's shown inferiority or, that when you give half the people transplant, half the people something else, that auto transplant has been less effective than any other treatment. There has not been any study to date to show that. It's also the most cost-effective therapy that there is, believe it or not, on a month-to-month basis. It's the most cost-effective. And to me, it also can give the best quality of life because it's a steroid-free option. You do your transplant and then you're off chemo for, if you're going to be followed without maintenance, which is a reasonable option, then you have a prolonged period of time where you're not on therapy. And so it's effective, it's cost effective, and it's good for quality of life. Now, in terms of alternatives in Italy, I don't know what is and is not available. I know that in many countries outside of the United States, you cannot give two new agents at the same time. So for example, you would have to choose pomalidomide and dex instead of darapomalidomide or dex. If dara is even available, I don't know. And you may not even be able to use bortezomib, pomalidomide, and dex. Pomalyst in general is a very good drug for people who have renal dysfunction. It can be used on dialysis. It can be used with every level of kidney function. You have to monitor the blood counts when you take it, but I think all in all, I would encourage a transplant. I also think people are very anxious about it because it's scary. You're in the hospital, you're getting high dose chemo, you lose your hair, which can be very, very difficult. But I would encourage you to talk to another patient who's been through it because sometimes that can alleviate some of the fears. And it's very predictable. The side effects of transplant, we know what you are going to experience, when you are going to recover. There's really only 2 days where you're in a severely neutropenic state, meaning where your white count is dangerously low. It's 1 to 2 days. And the rest of the time you're being supported. And our treatments today are very effective in treating side effects related to transplant: antibiotic coverage, hydration, fluid management. But either way, when there's evidence of kidney problems, you need to be treated right away.
Okay. Another transplant related question comes from Susan. So she was diagnosed in 2014 and put on a 3-drug clinical trial, relapsing. How effective is stem cell transplant at this point? So
I would say it's effective. I mean, at first relapse, so she had treatment relapse. So this is the second line therapy.
yes.
Still a role for transplant. The longer you wait, the less that role will be. So after this relapse, it's very controversial. But there are people who call this what would be called delayed transplant. So it is in many institutions the norm. Where I used to be at Mount Sinai, they would give the option of delaying, harvesting the cells and then doing a transplant at first relapse. So you will get less of a remission compared to if you did it in the first remission, but it's still worth considering. And I think everybody who's eligible should have a transplant. It's life prolonging and it's in terms of quality of life beneficial.
Mm-hmm. Dr. Matsui, do you have any comments about that?
Yeah, I guess what I would say is that I am not as big a fan of transplant. Like, I think there's a utility to it, but I don't think that everyone should have one. I think that oftentimes we will offer patients a delayed transplant or transplant up front. I think that in my experience, most people who say, look, I'll do it later, just never end up doing it. And so I think that, especially in this age where we have other agents that we can use, I think that it's whatever the reticence, my sense is whatever the reticence was to have a transplant the first time around is probably not been alleviated during their myeloma treatment. So, I always talk to them about that early on. Like, I think beyond second line, I think is I don't think that there is a role. I personally don't think that there is a role. Like, a lot of people argue with me about this, but I don't think there is a role past second line. But I think that in terms of if you have a relapse and had been a consideration for a delayed transplant, I for sure will talk about that option again. But like I said, whatever the decision-making process was that led us to defer the first one or decide not to do the first one, I think is sort of there the second time around, and you sort of, and there are options. If there are no options, I think it's reasonable. But I think that, my own sense is that typically does not happen. There are, like, I think that if you have a very aggressive relapse that compromises, potentially organ function, then that might be a time to, it's a very fast way to get a remission. But I think that outside of that, I'm like I said, I'm not known in the field as someone who is a lover of autologous stem cell transplantation.
Okay, another question about Allo, actually. Bernard's asking, does Allo transplant disqualify someone for CAR T therapy?
So in many cases it does, which is very weird. And so, I think that one of the things to think about is that when you do an Allo, like, what are you looking for? You're looking for a new immune system, right? Because your immune system was no good, right? Because you didn't control the myeloma. So what you want is a new one. So if you look at data, CAR T cell data in different diseases, it has a different ability to quote unquote cure people, like create long-term remissions in different disease states. So if you look at aggressive lymphoma, at least a third of patients remain in a remission, probably beyond 5 years. So I think that those patients are probably have a chance of being cured. In the case, if you think about the other place where where it was originally developed was in acute lymphoblastic leukemia, or ALL. And in those patients, it's very, 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 very rare that it's curative. And most people, when you use it, is not to try to cure the patient, it's to try to get the patient in a remission so they can go to an allo transplant. It's a bridge to transplantation. So if you look at the ALL data carefully, the patients where it actually works and creates very long-term remissions is when you make CAR T cells. So you're taking T cells out of the person, engineering them and putting them back in. If the patient had an allo, because what you're doing is you're taking good cells out and making those into CAR T cells. So for the kids who've had the longest remissions with CAR T cells in ALL, those are almost universally patients who have had allogeneic transplants, right? So there was an interesting thing. There's a bispecific molecule from Amgen called AMG 701. And if you look at that data, like 11% of the people had an allo, which I thought was really interesting, because like, where are you finding these patients, number one? But I think that one of the things that would be interesting to do is, like, their T cells are maybe a little bit different than the T cells in people who have had no transplant. So I think that, like, allo transplantation is may be a very good platform to make CAR T cells, which, like I said, from the autologous setting, there's no evidence that they're curative. It may be that you can make them curative if you have the right T cells to start out with. And that may be in the post-allo setting. So there are trials that are starting to gear up looking at this question. And I think that, it's a fluky thing that I argue with CAR T cell companies a lot, is that why are you excluding allos, right? You're never going to, like, the fear is you're going to generate graft versus host disease. That never, ever, ever, ever happens. So I think you should be able to go ahead and include those patients. And like I said, in the bispecific trials, those patients have been included, but in most CAR T cells, it's an exclusionary thing.
So once these we have 2 approvals coming up probably this year, right? The BB2121 and the Janssen CAR T. So once those are approved, you could use it after, if you've gotten a prior allo, you could probably use it, right? It wouldn't be exclusionary, or would it still?
We don't know, because if the trial excluded these patients, then
Um,
the insurance companies may not pay.
It depends on what the label actually is.
So we don't know. We
yeah,
don't, we really don't know.
you don't know how it'll get approved. Oh, okay. Okay, that makes sense. Okay, another question from Joan was, if you relapse and the disease come back, can it come back with just a portion of the CRAB criteria? So she's had bone changes and is high risk. Could she have renal or other changes? Like, can you have one of the 4 CRAB criteria and not any of the others at relapse?
Yes, most of the time relapses repeat. So if you were a bony person in the beginning, you'll be a bony person at a relapse, but you can develop any of the CRAB symptoms at any time. So at diagnosis, only about a third of patients have kidney dysfunction, but throughout the course of their illness, 2/3 or more of patients will develop kidney dysfunction. And part of that is due to treatments or, side effects of treatments. And part of that is due to new myeloma kidney. So myeloma can affect the kidney even at later relapse. And that's why it's important to do 24-hour urines and keep a close eye on the kidney function throughout the course of the disease. Now, the other thing that can happen with each subsequent relapse is the proteins may not be secreted as much. And that's called oligosecretory or even non-secretory disease, where you think someone's fine, their proteins aren't showing up in their blood, their light chains are the same, their kappa, their lambda, or their M spike haven't changed, yet they develop a new bony symptom, a new fracture, or perhaps a high calcium level later on. That's not common, but it can happen. So you always have to, look at the blood work with a grain of salt and always be suspicious that the crabs can change with time.
Mm-hmm.
Yeah, I would say that the one thing that I always do if there's a sense of relapse is to redo bone imaging, because that's a place where even if you didn't have bone disease before, there's a chance you can develop a plasmacytoma, and that is something that you may be able to radiate. So I think that like standardly when patients relapse, I like to do a bone marrow and I like to redo bone imaging. And so that's something where you can be like, I've been surprised because people say, well, they never had bone disease, and then voila, you see it. So I think that that's one of the things I would say is part of a relapse workup is you should really repeat the imaging.
Mm-hmm. Yeah, and I heard from one doctor that they're not even doing PET CT anymore; that they're doing just full body MRI from now on, just to detect more
Yeah,
relapse.
I
Is
mean,
that?
you have to be careful because full body MRI is the most sensitive test to detect bone lesions, because what those MRIs are showing you is infiltration of the bone marrow.
Mm-hmm.
So you'll detect a bony lesion kind of when it's in the marrow before it even gets to the bone. So you'll see everything. You won't know if it's a real myeloma lesion, B, if it's old or new. So unless you've been doing MRIs from the very beginning, a relapse MRI is not going to be as useful. A PET scan, for example, has the advantage of showing you active or SUV avid disease versus sclerotic or old or healed disease. So I like to use bone marrow MRI surveys for my smoldering patients who I'm suspecting they're relapsing, and that will show me a very, very early lesion before it's even a real lytic lesion or FDG avid lesion. But at relapse, I tend to use PET scans more than MRIs. Or if there's a focal area that you're concerned about, for example, someone has neck pain, or somebody has numbness in their fingers, or someone has an area in the hip that's really painful, then you can order a dedicated MRI of that one area to better look at the bones and the muscles and the area in that one area. But if you're going to do a whole bone body image, then I like PET CTs.
Interesting. Okay, another question from Amy. Her husband was on KRDD, so Kyprolis, Revlimid, Dara, and Dex. Relapsed in about 12 weeks. Doctor was saying he was almost out of options. So after her experience, she's just kind of wondering, is there testing that shows which drugs he was resistant to? So I had, I had had an experience where I met with some of the German myeloma researchers, and they had said, we had treated a patient with Revlimid and Dex, and then they did some kind of genetic testing to show that he was actually resistant to the Revlimid, but had been getting Revlimid for a multi-year period, but was resistant to it on this test. So, is there a way of telling which drug you're actually resistant to?
So I think that there are two very, very intriguing things that have happened, most recently. So it's unfortunate that Dr. Shane is not on because he is sort of championing one of them. So at Moffett, they have a lab that's really dedicated to looking at myeloma cells, seeing whether they're sensitive to specific drugs in the lab, and then using that information to try and go and treat the patient. It's an impressive setup. It's hard to look at the data and say that there's like 100% chance of predicting something. Although if you take a step back, like there is nothing on the planet that is 100% predictive of anything in myeloma. So you have to take that with a grain of salt. The other is that there's a myeloma specialist at the University of Colorado named Dan Sherbinow. And so Dan has also developing a test to look at drug sensitivities in the lab to try and help with prediction things. So I think both of those guys are doing stuff that's really on the cutting edge. And these are the things that we need to help predict things. I think that it's really hard to, we don't have really great
Biomarkers.
genetic mutation things where we can match them up with like specific drugs, right? And so, you have that in like, let's say melanoma. You can have, if you have a BRAF mutation, you can use a BRAF inhibitor. But in terms of myeloma, we don't yet have that. And so I think these functional things where you actually get the myeloma and you test it may be more effective. And so, like I said, I think Ken is really Dr. Shane's really at the forefront of looking at this. And again, I think Dr. Sherbinow is really doing great work as well. And I hope that comes to fruition because it takes the guessing out of it, right? And that would be great.
That would be great. I think that'd be fantastic. So it's good to hear it's coming. Okay, Consuelo is wondering what might happen on relapse with a biclonal disease. So somebody has IgA, myeloma, and IgG MGUS. Are they more likely to progress to active myeloma or not?
No, I mean, we see these types of things fairly frequently. Sometimes we have an MGUS in the marrow and, in a tumor, like a sacral tumor, that tends to have a different clone, like IgA kappa, for example. That does not predict inferior outcome or poor response. The MGUS clone will probably go away just the same as the myeloma clone will go away with treatment, and you just monitor. And you may restore an MGUS state, you may not. Both clones may disappear. So I don't think that has any effect on response to treatment.
Okay, Rick is asking just kind of a general question on only one treatment for maintenance pommelus and then a relapse. Where would you go for next step? But that's kind of a broader. You need like to be, like you said, Dr. Matsui, like a historian too, right? What?
Yeah, I think it's hard. It's hard to know. Like it depends on what if there are other health issues, if there are other preferences. Like someone might say, "Oh, I want to go into the clinic every week and get an infusion," which I don't know anyone, especially who is COVID cognizant, wants to do that these days. Yeah. But that might be something. So I think there are a lot of, the good thing is that for most patients there are some options.
Yeah, we've talked
and there's some choices to be made.
Yeah. And you need to know a little bit more about that patient and the patient experience. Okay, Thomas is asking, can a relapse include a movement from standard risk to high risk? Is an 11-14 patient usually always an 11-14 patient? Do 11-14 patients usually pick up other high risk genetic features? That's a kind of an interesting question.
So I think that with 11-14s, they're classified as a better risk in general, right? I think that one of the things to remember is that risk categories are really defined by patients who are at a certain point. So usually at diagnosis, that's how we know what these features do, right? It's hard to know. So risk is very, very, very contextual. So if you now go and redo something, right? Like you go and you try to reassess risk, like after 1 or 2 relapses, after a transplant, whatever, there's very little data that tells us what that all means. Like if you have someone who had an 11-14 and you expect them, to do fairly well, and they have very aggressive disease, then obviously it's not acting like quote unquote what we would expect from 11-14. And I think that the other thing to think about is that risk is not like it's not a direct correlation with what is going to happen to you. It's a probability of what's going to happen to you, right? So patients with different cytogenetic abnormalities will have different sort of ranges of what happens to them. Some will do really, really well, like there are 17P patients who I have who've done really, really well, right? And so it sort of gives you an insight, well, what might happen, but that doesn't mean that that is absolutely 100% going to be the thing that happens to you, right? So I think that you have to take things in context. So we don't really understand genetic abnormalities in patients who have relapsed multiple times. What does that mean? You learn more about their relapses rather than the genetics to some extent. I think that, as far as getting additional mutations, all patients will gain additional mutations over time. And that's part of the clonal progression of the disease. And so it may be that there were clones that already had additional mutations that are now growing out, or is it that the clone that was there is now gaining more mutations? It's hard to know. But I think that typically you can see additional things happening, and whether or not those genetic changes are really telling you something outside of what has already happened to the patient, I think is very difficult to know. So I like getting that information just to sort of see, is there clonal progression? Are there other mutations that are coming up? But, do I really use that information in a very, very, very cogent way of saying, okay, if you have this, then we're going to do this? A lot of times I do not. That doesn't really come into that big a play.
And Bonnie's kind of asking a follow-up question on that. Are there treatment-related genetic mutations, additional genetic mutations that you will see, or no? Or you just see them and it's not really related to particular treatment?
I think you don't. Like, I think that there is some thought that, after an autologous transplant, you can develop other things, like you can develop MDS, you can develop other bone marrow problems, and that is, those may be influenced somewhat, but those are outside of the myeloma. I think with myeloma, there's not.
Mm-hmm. And Dr. Brand, Linda's asking a question. If somebody starts on venetoclax for the 11-14, is that just something they stay on and continue even if they have no M spike? Or like, that's kind of a new thought, right? Because it's not even FDA approved yet. So kind of a more complicated question, but what's your opinion?
Certainly, I wouldn't use it up front when we have, therapies that result in response rates close to 99% in the upfront setting. But in the relapse setting, if venetoclax is used, it would not be discontinued same as other therapies. It would be similar to using Darapondex. You stay on until disease progression. So venetoclax would be part of that. And in studies, it's given alone, it's given with bortezomib, it can be given with carfilzomib. So we have patients on various combinations. We do tend to use it earlier on if they are T11-14 because it works. It works very, very well. And the dose in multiple myeloma is much higher than the dose used in lymphoma. In lymphoma, you kind of have to ramp up slowly with venetoclax, start with 100 milligrams and then you may even need to ramp it up in the hospital. In multiple myeloma, patients tolerate 800 milligrams a day right off the bat. And some people might have GI side effects, but for the most part, most patients tolerate it very well, and it works. So I wouldn't stop it, even without an M spike, if it's working.
Mm-hmm. Okay. This is another question. We'll do 2 more questions because we're at time and it goes so fast. I can't believe the time is gone. Natalie's asking, so you mentioned that there are different types of myeloma, different parts of the body, and usually the bone marrow biopsy is always done in the back of your hip, but do you recommend bone marrow biopsies in different locations to spot different clones? Like, do you guys ever do that?
I mean, we do that in the context of clinical studies. So if we have, for example, a patient who has relapsed after CAR T and their tumor markers are excellent, are normal, their bone marrow biopsy shows no disease, but their PET shows a lesion, we do biopsy that lesion. We do an interventional radiology guided biopsy, meaning the radiologist will take a picture through the CAT scan and then direct the needle exactly where that lesion is. And that helps us, A, to make the diagnosis, and B, to get the genetic information. So if you, for example, have what's called a mixed response, where some areas are improving and some are not, you may want to do a targeted biopsy of that area that's growing to see what's going on there, what can we do? And the simple treatment to that is radiation therapy. If you have one area that's not responding to systemic chemotherapy, then radiation therapy is a good option.
Yeah, I think if you have these mixed responses and you really want to know, I think that's a reasonable way to go. I think in general, if you're just doing bone marrows and someone says, well, I'm going to do 2 instead of 1, like I would never ever do that. So, like there's some situations where, like staging lymphoma, we often do 2. But in myeloma, I've never heard of anyone, have had a patient volunteer to do 2. I'll
Yeah.
put it that way.
No, that sounds painful. So yeah, I don't know. Okay, I'm going to ask you a final wrap-up question because we've talked about this a little bit already, but Frank is asking, when do you see us emerging from this standard type of treatment to more personalized kind of myeloma care? And I'll let you both weigh in.
There was a paper just published looking at longitudinal data on thousands of patients and the genetic mutations, and it is uninterpretable to me. I mean, there are so many mutations that occur with each relapse and between different patients, and it's very, very difficult to put it together and to provide personalized medicine. Now, there are studies trying to do this. There's a 7 cohort My Drug study where based on your genetic bone marrow tests, you're put on a specific treatment to target that mutation. So that study has enrolled already a good number of patients. We'll see what the readout shows. Similarly, there's a My Checkpoint inhibitor trial where based on your tests, you're directed to receive a different type of immunotherapy. So I think this information right now, where it stands, is confusing, but we have mechanisms in place that are going to teach us, how to more individualize and personalize therapies. So more to come.
Yeah.
And what I would say is that I think that I think the future is that if we properly use the immune system, then it won't matter. So if you look at allogeneic transplantation, it doesn't matter what your risk category is. It's going to work. It has the same opportunity of working. And that is the case in myeloma. It's the case in leukemia. And so I think that the immune system can overcome a lot of issues that deal with sort of drug resistance, traditional drug resistance. And so the immune system works in a completely different way. And so I think that a lot of like what we consider risk is because you figure out what's going on and then you treat the patients with chemo. So that risk is really tied to giving chemotherapy. It's not tied to giving immunotherapy. And so the immune system is a really great sort of leveler of the field. And so I think I would say, look, I hope that we have one thing, it works, it cures everyone, and we're done, right? That would be great. So I think that might be part of it is immunity may negate a lot of that. And it is very confusing information. And, not only looking at one mutation. It's like you have to look at all of them together, and that makes it even that much more complex. So it's hard to do, but you know, like I said, the immune system, we're having these functional studies like Ken and Dan have, that just you throw on the drugs, you don't care what the genes are, and then you go. I think that would be great as well.
Mm-hmm. Well, I remember at the Austin meeting, you said something that really stood out to me. Like, said, "What's the best personalized cure for myeloma?" And you said, "If your immune system can figure it out and deal with it, that's
Yeah, I
the best
truly believe that.
personalized myeloma medication." Well, we are so grateful to the both of you for joining us today. Thank you so much. Again, if you are a myeloma patient, you need to be seen by a myeloma specialist. You can hear how it's both an art and a science, and it's so nuanced, and they are so intent in personalizing care for us as individual patients. So we highly suggest that you do that. We thank you so much for your time. Again, we thank our sponsors, Amgen Oncology, Adaptive Biotechnologies, Bristol Myers Squibb, Genentech, GSK, Janssen Oncology, Karyopharm, Oncopeptides, and Takeda Oncology. And again, just one more reminder, we will be running this genomics high risk. If you have a high risk feature, join HealthTree, because we'll start that study on Monday and you'll be welcome to join. And we like to provide this type of information back to the investigators for free so that they can learn from it from us. And that's how we can contribute to our own cure. So again, Dr. Brown and Dr. Matsui, thank you so much for joining us today.
Thank you. That was great.
Thank you very much. Thanks for everything you do. Bye, guys.
Thank you.